Good morning, everyone. A warm welcome to you all to this unique program with uh, Sunday special 60 minutes with psychiatry teachers. Me, Dr. Gopal Das. I'm working as an associate professor in Basaveshwara Medical College and hospital in Chitradurga, Karnataka. I've recently concluded this first edition of IToP's STEPS program. And today I have the privilege of raising the curtains of this unique program of Sunday special 60 minutes on behalf of IPS UG training task force and PG training task force and also Minds United for Health and Humanity Trust. So as we all know, this is a joint initiative of IPS Faculty Training Force, IPS UG Education Subcommittee, IPS UG Education Subcommittee, and this Sunday special 60 minutes with psychiatry teachers is a unique program, a pan-India platform to share experiences. This was inaugurated by IPS President Office Bearers on 28th March 2021. And all the programs, we have probably had some 60 to 70 speakers already who have shared their experiences in UG and PG teaching. And all the recorded programs are available with the shared link, which will be circulated throughout the groups. And right now, South Zone and East Zone have actively participated here in previous programs. This provides a free online platform for every event. Dr. Professor Kiran Kumar of Vaidehi Institute of Medical Science, Bangalore will be our key coordinator, and he has been. Unfortunately, today he is having some other engagement, and he might join us late. And this has 60 minutes. Usually starts from 11:30 to 12:30 on a Sunday, and each faculty of psychiatry are invited to talk about his or her challenges and lesson learned, but only in relation to teaching and learning experience in undergraduates and postgraduates. 15 minutes will be allotted to professor or associate professor cadres, and 15 minutes for the younger early career teachers, including assistant professors or senior assistant, and 5 minutes will be reserved to UGs or PGs to share their learning and teaching experience, followed by 15 minutes of discussion and 10 minutes of opening and closing remarks. This will be restricted only to 100 first first come first serve basis, and this will be open for all psychiatry teachers, psychiatry postgraduates, and medical students. And interested individuals who are keen to participate can email their outline, the talk to the given email IDs, which will be shared over platforms. And now, without delay, I'll hand over the program to the moderator, our beloved friend, Dr. Ajay Kumar, who is Associate Professor in AIMS, Raipur. Sir, Dr. Ajay Kumar, I'll hand over the session to you and introduce the speakers of today's program, sir. Thank you.
Thank you, Dr. Gopal Das. And thanks to the organizing committee of this program to provide me the opportunity to moderate this session. As told by Dr. Gopal Das, this program is for the teachers of psychiatry, people who are interested in psychiatry teaching. And we have two prominent speakers for this program belong to the central part of India. One is from the Orissa, Bhubaneswar, and other is from the Chhattisgarh, Bilaspur. And I'm Dr. Ajay Kumar, Assistant Professor in the Department of Psychiatry, All India Institute of Medical Science, AIMS, Raipur. So we have first speaker, Dr. Ranjan Mishra, who is head of the department and associate professor, additional professor in the Department of Psychiatry, All India Institute of Medical Science, Bhubaneswar. And he has excellent academic career, and he is known for his dedication to psychiatric training. And with this introduction, I would like to invite Dr. Ranjan Mishra to share their experience of psychiatric training. To you, Dr. Ranjan Mishra. Sir.
Thank you, Dr. Ajay, for this kind introduction. And my regards to all my seniors and all my colleagues. Without doing much delay, I would like to start my presentation right away. Am I audible to all of you?
Yes, sir. Yes, sir. There is some noise in the background, but it's okay.
Yeah, yeah. So are my slides visible? Are my slides visible?
Yes, sir.
Yeah. So I'll be speaking today on the barriers in postgraduate psychiatric training. And this is a very interesting area which we often, in a everyday basis, we find some lacunae in our curriculum, in our training, in our research section. And this is a right platform where we can unitedly look upon the issues at a minor angle. And I'll also try to give few recommendations which we can practice in our postgraduate training per se, and that will help in improvising the training quality at the large. Next. 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 Yeah. So first, what is the need for a PG psychiatric training? So for that, we need to understand the mental health burden of our country. According to the National Mental Health Survey in 2016, the mental health burden is huge. It is around 10.6%. And when we talk about the mental health gap, the survey in 2016, the mental health gap has been huge. It's ranging from 70 to 90%, 70% in certain states to a large of 90% in certain states. And the number of psychiatric training institutes in our country is also limited, which can cater psychiatric services. It's almost psychiatric training institutes are 221. And coming to the number of psychiatric seats, it's around 882 psychiatric seats, postgraduate psychiatric seats. And when we look at what is recommended for our society is like at least we should have one psychiatrist or one mental health professional per 1 lakh population. But if we see for the statistics, the number of psychiatrists, the range has been varying from 0.5 to as low as 0.52 in certain states like Madhya Pradesh and central part of India, and to some states where it is around 1.2 that is in Kerala. So if we look totally at the psychiatric trainee index, the psychiatric trainee index is less than 1 in most of the states, which is much less than what is recommended for a good psychiatric care. Now, next, I'll come to what are the components of PG psychiatric training. I'm sorry for the background noise. Actually, a conference is going on from where I'm presenting. So I'm really sorry for the background noise. I'll speak about what are the essential components of a PG psychiatric training. So the training comprises of the clinical teaching, or exposure in clinical subspecialties like addiction psychiatry, child and adolescent psychiatry, community psychiatry, and neuropsychiatry. An essential component of PG psychiatric training is the consultation liaison services and how you are going to approach emergency psychiatric situations. The components, if we broadly divide the training per se, it comprises of the academics, the research, the publication, and the clinical work. Coming to the academics, which we deliver to our PG students, it involves bedside clinical teaching, didactic lectures. Didactic lectures, when like what we practice in our institute is when the PGs come, in the first 6 months, we give didactic lectures on the major subjects like depression, bipolar disorder, schizophrenia, OCD, etc. And secondly, we also do something that is what is called as the Psychopathology Lectures. We have a separate section for Psychopathology Lectures. Along with that, we encourage small group teachings where we can discuss about the phenomenology of some patient. We can discuss about some short topics, and it is a small group discussion. Usually, the number of participants are usually less than 10. Then encouragement of the CMEs and encouragement for workshops. Then the research, that is the PG thesis that is given. They have to conduct it over a period of 2 years, and 6 months before they appear for the final examination, they have to submit it. And finally, the publication. Now, coming to the problem in psychiatric training is basically from more attitude towards psychiatry. We all know that psychiatry had been a subject carrying stigma for decades. And this stigma can be seen across different corners of the society. This stigma you can see among parents, where they do not want their child to be doing their post-graduation in a subject which is stigmatized. Among medical students also, if we see, the exposure to psychiatry in their medical in the undergraduate training. So think of a situation where a resident joins with such a background, so it can create doubts in that resident's mind whether I will go for the subject, whether I am going to continue the subject. And finally, the attitude among the medical fraternities also. In most of the psychiatry setup, if you agree with me, psychiatry subject is always taken at a back foot, and usually the medical fraternities, even if they are having some kind of psychiatric problems and psychiatric issues, they have a stigma towards the subject. So this stigma often you can find in patients who are attending medical medicine OPDs and gastro OPDs. Many cases you can find having social disorders, but they are not adequately referred to. So there is a general lack of attitude towards positive attitudes towards psychiatry as a discipline. Next, I'll come to the administrative barriers. There is lack of infrastructure, many places, lack of PG seats. I'll quote you an example of RIMS Ranchi, which is an established medical college, but till 2010 or 2011, there were no PG psychiatric seats. That is the scenario in most of the medical colleges of the country. And the student to teacher ratio, the student to teacher ratio is also like it is not proportionate. I will give you an example of my institute from which I passed, Central Institute of Psychiatry. At one point of time, there were only 6 faculties who were catering their services to almost 20 PG students per year. That is the scenario in most of the places. There is a lack of allied departmental liaison, like clinical. Most of the new ends also are facing this problem. Most of the places there is no attached clinical psychology unit or psychiatric unit. So it's very close to the patients. There is lack of lab, lack of basic EEG labs or neurophysiology lab, and lack of equipments in most of the centers. And mostly there is a poor CL structure in anesthesiology services, and many centers, all of you will agree that this liaison is not being possible. So in many centers now ECT is not being given regularly. The problems in that
Sir, I think we have lost the connection with Dr. Vishwaranjan.
There is some network issue. Now, am I audible?
Yes, sir. Yes, sir. You again joined.
Yeah. So there is a limited exposure to subspecialties like adolescent child and adolescent psychiatry, addiction psychiatry. So there are certain centers which have this these specialty services, but there are centers which do not. So every center should encourage exposure of their residents to these specialties. There is a lack of collaborative teaching, like the psychosomatic rounds, which we have in many places, that is lacking in many other centers. So there is a lack of collaborative teaching. And most importantly, the biases in assessment. I will tell you something which has been there with me from the very beginning I entered into the subject. I strongly recommend that the assessment of the residents should be longitudinal rather than cross-sectional. A last day performance and how you are presenting your long case should not decide your pass and fail. So more importance needs to be given for the formative assessment rather than the summative assessment. And the assessment is also hugely biased upon your relationship with your peers, your relationship with your faculties and professors. Now, another issue is the barriers in research. Most of the PG students have to choose their research topic by the end of third month of their residency, where they're barely exposed to the subject. So the choice of research is usually done by the guide. So there is no independency for the students to take up the research by choice. And there is lack of funding for the research. And mostly importantly, there is limited access to scientific databases in many places. And there is no clear-cut defined timelines for research submission in many places. So these are the basic problems in research. Next. Now, next. The problems in what resident might face is they're coming from a long distance, leaving their house, and suddenly they're exposed to a new situation, new environment, new food, new culture. And at one point of time, they're overburdened with work and the rules and regulations of residency. So there can be issues where there can be mental and physical health issues with the residents. There can be issues of burnt out. They can be overworked, homesick, and at times there can be relationship issues and IPR issues as well. And most importantly, after the residency is over, there is insecurity. Like after my residency is over, if there is no senior resident post or any pool officer post, what I'm going to do? So there are some forced problems, like situational problems, like there are some forced duties which are given to the residents. Like in our place, the residents have to perform 3 months of duty in trauma and emergency. So it's a forced duty, which is not going to be beneficial. But for administrative reasons, it is being forced, and we cannot do anything about it. The COVID pandemic had a big toll on our residents, and most importantly, these issues can culminate and finally lead to a brain drain. Now, with this background, what are the expectations we have from the PG psychiatric residents? With this background, a person who has come with a limited exposure to psychiatry, we are expecting, with so much of limitation, we expect that there should be competency in the clinical services. The resident should be competent in giving emergency services and applying the psychiatric knowledge in CL setting. He should also have basic statistical skills and able to formulate scientific research. After he passes, he should be able to perform teaching of the undergraduate and postgraduate training, as well as he needs to maintain ethics in his practice and research and continued learning. So what I would give recommendations for the modifications to be done at administrative level, there has to be an adequate infrastructure for psychiatry. It should not be pushed to one periphery. Rather, psychiatry as a unit should always be a part of the general hospital services. It should be a part. It should, in many places, it is given isolated place. That should not happen. Maintaining the correct patient is to doctor ratio, and maintaining the teacher is to trainee ratio is important. Integration of allied services like clinical psychology and psychiatric social work, and facilitating interdepartmental trainings and activities. At departmental level, what is most important is a uniform standardized curriculum that should be adopted as a uniform across each part of the country. the assessment tool, that is the case record pro forma, should be uniform. Like in CIP, the case record pro forma is different. In Enhanced, it is different. In AIMS, PGI, this is different. So a few people, few of the centers follow the FISH school, and few of the schools, they follow the Nancy Anderson school. So there can be problems, there can be confusion or doubts in the mind of the resident. So that the assessment tool has to be uniform. And if somebody is coming for assessing the resident, they have to be flexible, that what has been trained, what is the thing that has been practiced in that particular center. So the examiner has to be flexible for that. There has to be a mandatory subspecialty exposure, that we have a exposure, 1 month exposure, 2 months exposure in mental institutes like NIMHANS or Central Institute of Psychiatry. Then there should be community exposure, and most importantly, what I told you, the assessment, more importance has to be given on formative assessment. Formative assessment can be best done when we have give more weightage to the logbook. And if you see in our curriculum also, very less proportion of marks is given for the logbook. So eventually everything stems down to a summative assessment. So more importance should be given to the formative assessment, and more marks should be given to the logbook. Encouraging cross-institutional training, like training initiatives for psychiatric postgraduate, that is TIPS, that has been initiated in 2020. There is a NIMHANS Indian portal where you can get cross-institutional training from NIMHANS. There can be periodic webinars, and CMEs should be encouraged, and institution of travel and research grants should be provided. Now, for facilitation of research, our center also, for PG research, there is no institutional grant. So we cannot plan a good study which involves some funding. So there has to be an institutional grant for the PG students. The ICMR provides a 50,000 grant for PG thesis, and luckily this time our resident has got that. So every PG student should discuss with their guide and apply for this ICMR PG thesis grant. There should be an open access to the journal database. And we know that the institutes only allow the residents for their database. So this is a problem for people who are coming from different institutes. So the journal database should be open, and there should be facilitation and guidance towards possible publication. Like something can be done, like once a resident is able to finish his thesis before applying or before giving the MD exam, he should be encouraged to at least send his article for a potential publication in some indexed PubMed index journal. And finally, most important is there has to be respite, rest that should be given for the mental health care of the residents. So these are my references, and thank you all for a very patient listening. And after Professor Sujit Naik delivers his talk, at the end, we will be taking up the questions from the floor. Thank you all.
Thank you, Dr. Ranjan Mishra. We have crossed a little bit of time, so I just introduce our next speaker, Dr. Sujit Naik, who is very senior professor and head of the Department of Psychiatry in Chhattisgarh Institute of Medical Science, and he has long experience of teaching. And with that, I would like to invite Dr. Sujit Naik to share their experience of psychiatry training at undergraduate level. Thank you, sir.
How can I share my screen?
Dr. Ranjan Mishra, please
Just
stop sharing the slides so that, okay.
Okay, that can. Hello, I am Dr. Naik. Hello, can
Welcome,
I start?
Yes, sir, please start.
Can I start? Am I audible now?
Yes, sir, you are audible, sir.
Yes. Hello. Okay, ठीक है. You can reduce. ठीक. Yeah. I'm Dr. Naik. I'm Dr. Naik, Professor, Department of Psychiatry, SIMS Bilaspur. Thank you for your introduction, Dr. Ajay. The topic that I wanted to speak is regarding training in undergraduate students. The barriers have already been discussed by Dr. Mishra, and he has made it easy for me. Okay. To put the topic of discussion in perspective, I will skip through quickly. Dr. Mishra has already told about the burden of mental illness in the country. The Global Burden of Disease Study 1990-2017 reports 197.3 million people in India suffering from mental disorders, and 1 in every 7 Indians suffer from mental disorders of varying severity. The contribution of mental disorders to total disease burden has doubled since 1990. The National Mental Health Survey has reported 13.7% lifetime and 10.6% current overall weighted prevalence for any mental morbidity. And WHO estimates in our population currently of around 1.35 billion, the mental health problems is in the tune of 2,443 disability adjusted life years per 1 lakh population. Most of the mental health care delivery that our country resorts to is through the primary health care, and the National Mental Health Survey through state mental health systems assessment has reported mental health programs and activities in India, they are fragmented, disorganized, and they receive a very low priority during implementation. Interestingly, almost 1/4 of the total case load of mental disorders we see is in the primary settings, which are most often missed or inappropriately managed. For this delivery of mental health care, the resources that we have is very meager. And as per the World Mental Health Atlas 2014, the estimates, the figures of psychiatrists in the country would be 0.3 per 1 lakh population. The National Mental Health Survey puts it to 0.05 to 1.2 psychiatrists per 1 lakh population, lowest being in Madhya Pradesh and highest being in Kerala, of among the 12 surveyed states in the National Mental Health Survey. Garg et al. In a recent study in 2019, they have calculated the total number of psychiatrists as 9,000, and the number of postgraduates somewhere between 700 to 800 per year, puts the figure to around 0.75 psychiatrists per 1 lakh population, whereas the desirable, like Dr. Mishra said, is around 1. But as in National Mental Health Survey, but the figure would be probably better anywhere more than 3 psychiatrists per 1 lakh population would be much desirable, keeping in mind the figures for Western countries to be around 6 psychiatrists per 1 lakh population. So with the limited resources that we have in terms of manpower and the resources that is there in the country, there is a huge treatment gap. And this treatment gap ranges from 28% to 83% as per National Mental Health Survey. Many other factors besides the limited resources, human resources and infrastructure are also contributing, like lack of awareness, affordability of care, and stigma of mental illness. The National Mental Health Survey also found that almost 80% received no treatment despite having the symptoms of illness for more than 12 months. Coming to the training of psychiatry of undergraduate students, as of now, MCI until now had allocated 20 hours of lectures, tutorials, and seminars, and the clinical posting was done in 5th semester. The assessment, the summative assessment was in paper 2 in medicine, where only one question from the medicine and allied subject was there. And there was a 2-week posting in psychiatry during their posting of general medicine during the compulsory rotating internship. There is also elective posting, many of 2 weeks, which is usually mostly not opted by the students. When you compare that with the NMC has the competency-based curriculum initiated since 2019. Only 2 batches have now gone into this schedule. The allocated number of hours have increased now to 40 hours, including the lectures, tutorials, and self-directed learning, which is a very positive step. And the clinical posting has again been hiked in the second and third professional to 2 months. Like 2 weeks in second prof and 2 weeks in MBBS. The marks assessment, in the assessment, the marks allocated is also more in paper 2, where you have psychiatry and other medicine allied subjects as 50 marks. And they focus more on the curriculum, the competency based curriculum focuses more on the competencies and the skills, and it provides a standard and framework for measuring the performance. The assessment type is more of a formative nature. Intensive posting is same as per the previous schedule of MCI. So there it goes. There has been some change in the current competency-based curriculum from the previous MCI. The positive step being that the hours of training has increased, which has been a demand since a long time. Coming to the barriers to training in psychiatry, let me put that in 3 headings: teachers, students, and curriculum. Now, coming to pertaining to teachers, the things that will probably matter is the personal characteristics. Personal characteristics meaning many people, all the good teachers will require, the requirement of a good teacher probably will be skills in communication, listening, collaboration, and engaging the students, having a lot of patience. More or less, these are the characteristics. So that is very variable from teacher to teacher, so which might be a barrier to teaching or training. Then there are teaching and learning methods. Earlier, the teaching learning methods that was there was mostly didactic lecture and some bedside teaching, keeping in mind the duration, which was very less. It was not adequate. The teaching learning methods now in the curriculum based, the competency based curriculum is more or less the same. The lectures are there, but there are also they have also included small group discussions, and they also require DOAP session, which means demonstration, observation, assistance, and performance sessions. And the assessment again is through Viva, but they have also added one skill assessment. Either the skills that are there is through the skill station, through the skill lab, or directly bedside or patient related. There is one more problem in the medical colleges, is that the staff that is there is inadequate, and whatever inadequate staff that are there, they have additional administrative responsibilities. If I go by my experience, I joined this institute in 2002, and I worked until 2012 as a single staff in the department. The training that was supposed to be done for 100 MBBS students for a single staff with the given amount of grouping, and then intensive training was very difficult, is practically not justifiable. And then on top of this, there are additional responsibilities in administration as all the teachers become senior. Then coming to inadequate training in the new curriculum, the competency-based curriculum that we have, still the teachers have not been trained in that, although the second year has already started their tenure, and the posting is yet to happen, and the directions that is there is 20 the competency based curriculum needs to be put in force in a phase wise manner, around 20% at a time is the instruction as of now. The additional burden of coordinating again between the disciplines has to be kept in mind for the integration, both horizontal and vertical integration as per the competency-based curriculum between the different departments regarding various topics. Then there is barriers with regard to student. Pertaining to student, the attitude that is there, students that initially come and come into the medical curriculum are no different from any lay public, and we all know how far the idea of mental illness goes into the population. The knowledge regarding the psychiatry, the response to mentally ill persons. So the students probably are part of the same group when they enter into the curriculum. But as gradually there is training, the things changes. The things changes, and this attitude is a big barrier. Many people still find it the psychiatry is the least important subject. One of the studies in 2007 shows that very clearly. And they find the other subjects as much more challenging, and this not being as important, probably because of the subject not being assessed in the final examination. And then there is the attitude with regard to career. With regard to career also, many people usually do not opt, even in the Western countries. They find it that the choosing of the option is very low. Many people do not also fare better with regard to psychiatrist being a role model in finally somebody with or without the discipline of psychiatry practicing as a clinician. And then the attitude towards mentally ill. Although we have found definitely, as I said, that the attitude improves with training, there are also studies where it shows otherwise. The attitude probably will improve as we think. In the study of Gulati et al., that is in 2014, the improved attitude is very clear. With regard to curriculum, Dr. Mishra has also already talked about the various issues. And the duration of training here, is quite less, which has been a demand by the IPS to make psychiatry a separate subject, so that the assessment and the emphasis on the subject is much more. The student, most of the assessment in the medical curriculum and the learning in the curriculum is mostly assessment driven, so that would probably help. And this is going to go a long way when finally people join their different careers. And finally, it is going to have an impact on mental health care delivery and mental health in the country. Thank you.
Thank you, sir. We have crossed a little bit of time, and that we try to cover later part. So we have now come to the different stage of the program, that is perspective of the students. So I would like to invite first student, who is Dr. Chinu Patra. Dr. Chinu Patra, are you there?
Yes, sir.
So she is basically first year PG student from AIIMS Bhubaneswar, is it? And
Yes.
yes, so please share your perspective briefly.
Thank you, sir. And I'm very thankful to the organizing committee and my faculty to have given this opportunity to express my views and experiences as a first year junior resident in Department of Psychiatry. And I'm Dr. Chinu Patra from first year junior resident, Department of Psychiatry from AIIMS Bhubaneswar. I would like to say that, as we all know, that learning is a continuous process. So my journey began with preparing a peripheral smear in physiology department, then to eliciting deep tendon reflexes in the final year, then various clinical postings in internship, and then suddenly joining the PG subject that I have chosen myself. And it was not as a last resort that I have chosen. I always wanted to take it up as my career. So from eliciting deep tendon reflexes to eliciting psychopathology, the delusion, the hallucinations was a huge transformation for me. So initially when I joined the institute and this new subject, like we are previously exposed to, like any other subject, if we consider surgery or medicine, we have a basic idea what we are going to do further if we take it as a profession further. But in comparison to that, when we look at psychiatry, we're not that exposed or not much information is available with us when we take it up as a PG subject. So in that way, I would like to change this teaching pattern, that even in the undergraduate level, or even if we are in the internship phase, we should at least get minimal amount of time to adjust with the new terms or new terminologies. At least we should have the basic idea, and it should not be a direct introduction to the new terms or huge terms directly when we join as a PG. So that would be better. And like there were, when I entered the PG course, it was a completely new environment for me. And since I belong to the state itself, language barrier was not there for me. But looking at my other PGs, first year PGs, they had a certain amount of communication problems due to language barrier. So that is also a kind of setback for them. They have to learn the language itself and then go on to talk to the patients. And if you don't know the language properly, it will be very difficult to elicit the psychopathology as such. So, and it is different from like other subjects. Like we first learned how to perform a suture on the wound initially in the internship itself or in the undergraduate days itself. But when it comes to psychiatry, we are never we never come across those terminologies or those terms which suddenly you get to know in the first year. So a graded and a slow exposure to all the terms or the communication skills or the interview techniques would be better in a long course. And now the preference of subjects, like choosing psychiatry as a PG subject, it has changed from what it was earlier. And with the when the COVID-19 pandemic started, after that, I get a lot of questions from my other fellow colleagues or the aspirants who are preparing for it right now. They also want to take up this subject as by their personal choice and not by something that it is the last resort or will get it at very low rank or something. So their knowledge about this subject is also gradually increasing. I won't say that it has completely it is left out of the stigma. It is still there, but people are coming forward and they are choosing this subject as the first choice, not as the last choice, which was earlier very prominent. And so in this way, if we start from the grassroots level itself, and like in the internship or the undergraduate level, as I have mentioned earlier, in all the colleges, if we can give it a try, it would be a better option for them too. Those who are even have a little interest in the subject, they can be more familiarized with the whole set of psychiatry terms or the knowledge they should have gained. It will be helpful for them. And next, coming to the new terminologies or the interview skills, this has to be learned, and with the time, means we when we sit with the consultants or the faculties or our seniors, obviously we have to look at them, look at their interview techniques, and then we can learn from them in a better way. So initially it was very problematic and difficult for me to probe into certain aspects of the psychopathology or elicit some phenomenology. But with time, with like after 6 to 8 months, I gradually learned how to improve my interviewing skills, and I'm in a learning process too. So it will take me a long time to improve me further. And during when I joined the course, after 2 months there was COVID lockdown too. So there was a problem in my thesis work too. So we were not able to recruit our patients or formulate even a protocol for submission. So in this COVID lockdown period, we had to also communicate to the patients through telepsychiatry. And just after 2 months, it was very difficult to even interview the patients over the phone, because it was difficult earlier to even interview to the patients face to face. So over phone, it was another level altogether. So these were some of the problems that all of the first years in every institute, I think, who have joined the course must have faced. And I'm just trying to elaborate and represent all of their experiences or views which we have faced all together. And in the upcoming future, when I find so many aspirants who are willingly means able to choose this subject, as other faculties have also given few suggestions about the training and the curriculum, I would be happy if that would be implemented, and at least to some extent. And that would really help people like me, a naive student. When I joined this course, it would help people like me to to make it easy, to make our journey a bit easy for the upcoming aspirants who are willing to join the course. And with this, I would like to say thank you again and express my gratitude to everyone to have given me the chance to express my views. Thank you.
Thank you, Dr. Chinu Patra. And you very very correctly said that moving from eliciting tendon reflex to the hallucination is a quite a lot transition, and hope best wishes to you. Then we will move to the next student, who is an intern from the Chhattisgarh Institute of Medical Science. His name is Dr. Saurabh Rathi. Dr. Saurabh Rathi, are you there? Please share your experience as undergraduate.
Yes, sir. Thank you, sir. Good afternoon to everyone. My name is Saurabh Rathi, currently doing internship in SIMS Bilaspur. I am here to share my views and experience of what I have learned from the psychiatric classes, posting, and internship duties. Grossly speaking, our SIMS psychiatric department is very much supportive and cooperative, and the teachers are the main pillar and the key source of knowledge. Coming to our first psychiatric interaction, the psychiatric posting started in the 5th semester, and the 20-hour lecture started in the 3rd prof, with the exam of psychiatric taken in the final 4th prof. The duration was quite long for us that time because being a student, we had to memorize a lot of things and which felt like a burden to me. Generally, the lectures were theoretical and sometimes exhausting too. But the real struggle was to attend class after the lunch break. As a medical student, I feel the more of classroom-based studies could be replaced by ward-based bedside patient studies and video-based studies, and giving a medical student the opportunity to sit in OPD and to write OPD slips under the professor guidance, which will increase their interaction with the drugs, with the patient, and the disease. As a medical student, I had a low mood of interest in psychiatric, and I used to sit in the last bench and sleep so that I can go room and watch my Netflix series, which I think which was wrong and which can be replaced by allotting a patient and asking to give a presentation on the patient disease and the treatment as a whole. And at the end of semester, a healthy Q&A session with the professor would be a good idea. But the notes provided by our faculty were short, simple, brief, and were very helpful and easy to grasp. In the posting hours, we used to visit patients where the main emphasis was on taking history and to improve our language and communication skills and to make us a better listener then rather than making a complete diagnosis. More or less, I think the psychiatric postings helped me a lot to get my internship happily and easily. The internship days were quite interesting and more fun for me personally because I felt it was a nice short roller coaster ride of 2 weeks where the working hours were divided and we used to visit ward and OPD. The ward made me learn to look after the patient and the treatment and the disease. The OPD provided me an opportunity to see a variety of patients. Some frequently seen cases were like bipolar disorder, schizophrenia, and substance abuse psychosis. According to me, the psychiatric internship was a kind of experiential learning during which we take the opportunity to apply the acquired knowledge and skills of our med school training to real world situation. And it provided an opportunity to integrate and consolidate our thinking and actions. In SIMS, I feel our department is up to the mark and the infrastructure is decent with separate sections of admission for men and women with separate washroom with good security system. If I would get a chance, I would like to add a few things beside medical treatment for the patient, like including indoor and outdoor activities and yoga sessions for the patient, and some entertainment facilities like including TV, music, aquarium for the patient, and for better surveillance, including an installing camera system. Now giving break to my words, at last I would like to say that overall the department was very much cooperative and enthusiastic, whether it was about our teaching or about the nursing staff or guard. It was wonderful experience and fun loving for me that how we came to know not only about the mental thinking and problem related to the people, but also how to treat them. So I feel psychiatric field can be taken as a career option in future, and I would think and I would like to go for it. Thank you, sir.
Thank you, Dr. Saurabh. And if you take psychiatry, I promise that you will not be disappointed. We are there to help you out. Okay. So with that, we have finished all the speakers and the student perspective. And as we have little time, then I would request Dr. Mohan Hasek sir to comment over the speakers and conclude the session.
Thank you, Ajay, for asking me. I know, you are concerned as a coordinator about the time, That is because this is called Sunday Special 60 Minutes with Teachers. I think the organizers who started this program, I'm referring to Kishore, Vinay, and others, including Ajay, they thought that Sunday mornings are too valuable. You have to watch a morning show. I know from the last speaker, Netflix series are very important, very interesting. The paper, the Sunday paper that I read, the Deccan Herald in Bangalore, the front page is about every Sunday. It's about new Netflix series, etc., etc. So that is why the organizers have this concern about not exceeding 60 minutes. But why I said this is that I note that there are not many people attending, and I might take a few minutes because I want to make few comments about the presentation today and my own perspective. I think today this announcement of this, the particular brochure says this is 11th or 12th edition of the Sunday School. I've had the pleasure and privilege of attending most of them on Sunday mornings, and I have learned lots of things. I have listened to a lot of people whom I have personally not known, seeing them. It's a very good way of getting to know people in different parts of the country. So I'll first say a few things about my own impression of this program. We are getting glimpses of what is happening as far as psychiatric teaching is concerned at the undergraduate level and at the postgraduate level in different parts of the country. I have largely worked my work in Bangalore in NIMHANS, which is, of course, a kind of a pilot institution. People who are trained here have gone to different places and we have been in touch with them, we know. But in the last few weeks or the last couple of months, what we have been learning from this, teaching of psychiatry, undergraduate and postgraduate teaching is new thing for me personally, because we are learning from a part of our country where at least I am personally not very familiar with. I'll tell you why. Last such program, it was from the Northeast, from the Regional Institute of Medical Sciences in Imphal, Manipur. I'm sure in major parts of the country, at least in South, people do not know about what is happening. And, the speakers talked about lots of very exciting things which are occurring. Now, for today's program, for me, I have heard of AIMS Bhubaneswar. It's one of the several new All India institutes which have started. I know some of the staff personally, but I didn't know very much about how things are, who are the people, who are the, and at least Bhubaneswar is an All India Institute of Medical Sciences, but Chhattisgarh, the Bilaspur CIMS, I learned that it is called Chhattisgarh Institute of Medical Sciences in Bilaspur. And I could hear Dr. Naik present very, very important aspects about problems in undergraduate psychiatry. So this is probably central India. Again, not much is known. People are there. Lots of things are. So personally, at least I've been very curious to know what is happening. Okay, so the other thing which I have mentioned also on previous occasions, that these are very, very meticulously and very professionally recorded. So it is not necessary that you have to actually, be physically present in this webinars to know what is happening. Because in the IToP website, I'm sure there will be all these previous ones which are available, which you can watch at your own leisure. Because Sunday mornings may be very important. You may not be able to sit in front of a computer or mobile on a Sunday morning between 11:30 and 12:30, but I'm sure all these are accessible at some place. Now, coming to today's presentation, because of another commitment, I could not listen to Dr. Mishra's talk. I came in, I logged in only towards the end. So I'll comment about the three things that I have learned. Starting from Dr. Saurabh. He has been very honest, which is very good. He has talked about his own experiences initially as a, like some of us, at least in the audience here, have been maybe traditional backbenchers when we were studying in medical colleges. When he said, I used to sit in the back bench and sleep, and then also watch Netflix series, I was reminded of my own medical college days about 40, 50 years ago. I studied in Bangalore Medical College. The gallery, the anatomy theater, If you sit in one corner of the back bench of the gallery, the professor who is lecturing will not know what is happening. The only thing that Saurabh has as an advantage, which I didn't have, is that time there was no Netflix. Now, of course, he can watch the Netflix series, and there are very, very many interesting things. I'm not saying it in a negative way. I also watch Netflix. In fact, some of them are very well produced. I watched a Netflix series recently. It is about a narcissistic personality disorder. I mean, it can be used as a teaching material in a very interesting way. I forget the name, but it was the key actors were Hugh Grant and Nicole Kidman. There were 6 series. It is about a pediatric oncologist who is loved by all their patients and family members as the person who gives them life, excellent, very well known, etc., etc. But in this, he is having an affair with one of the young boy he is treating in stage for Wilms tumor, I think, and has an affair. It's very interesting. Ultimately, one of the best and most realistic and intelligently made characterization of a narcissistic personality disorder. We all have here heard about the narcissistic personality disorder and Donald Trump. I recently read a book by Alan Francis, the creator of DSM-4, and a hardest critique of DSM-5, who says Trump is not a narcissistic personality disorder. If you diagnose him that way, that means that you don't know the definition of narcissistic personality disorder, which was originally drafted by Alan Francis. Anyway, I'm just saying that Saurabh was not really wasting his time. He may not have listened to psychiatry when the lectures were being held, but he is now doing internship and he has all positive things to say. He says also he has given us some clues about how psychiatric training for undergraduates can be made very interesting. Now let me talk about Chinu Patra's. So Saurabh, I understand, is undergraduate student in Chhattisgarh Institute, while Chinu is in the AIMS Bilaspur. I think that it is a good postgraduate training program. Listening to Chinu Patra, and also I must say that it's a good department because I know many people who are on the department as faculty. Besides the head of the department who spoke today, at least I know 2 people. One is Surabhi Patra, who shares the same Patra surname with the speaker of today. Surabhi came to Bangalore for a leadership and professional skills training program. I still remember, if I'm not mistaken, she won the best presenter in that highly contested, the presentation award. I'm talking about the early career psychiatrist workshop, and she came probably many, many years ago, 7 or 8 years ago. So I understand if things have not changed on the faculty. So it has to be a very good postgraduate training program. She has made several points about how the postgraduate training programs have to be improved, what are the barriers, etc. Now, I must refer to Dr. Naik's presentation, which I heard from right from the beginning till the end. He has hit on the nails of all the problems. He said that he was a one-man department from 2002 to 2012, 10 years, 100 students. Now, lots of things he did mention about how psychiatric training at the undergraduate level can be made more interesting. There should be more of practical training. The teaching, learning methods have to be much better, different from what is occurring today. There should not be too much of classroom teaching. There should be more clinical bedside teaching. Now, all these are possible only if you have more teaching staff. AIMS Bhubaneswar, being an all India institute, probably has much better teaching staff as Chhattisgarh. The current head himself said he was one-man department. This is the situation, unfortunately, in large number of our medical schools, at least 50% of the medical schools. In the last session, I mentioned this, that he is the head and tail of the department. If you are the only one-man department, then there's no thing in saying that you are the head of the department. You are the only one. Anyway, I would think that Bilaspur Institute Psychiatry Department, things should have improved definitely by now. They should be, because even the National Medical Commission or the IMC requires more people. I know at least in South, in many private colleges, there are more people in the department, but only the board is there. The white coat may be on the chair when the IMC people come in for inspection. They might be people. Again, I'm not saying it in any jest or anything like that. This is a sad state of undergraduate psychiatry training, and that's one of the reasons why I personally attend whenever I can this, because you learn, you create awareness. The number of teachers who are there will become much better teachers. And Dr. Naik also, Saurabh said teachers are the main pillars of teaching. And Dr. Naik said that, the various characteristics of a good teacher, personality characteristics. You should have patience, etc., etc. The point I want to make is that none of us are that way born as teachers, except very few of us. But we can definitely become better teachers if you follow many of the points that Dr. Naik mentioned. The personal characters, skills in communication, skills in collaboration. You have to have a lot of patience. Many doctors are not, although they treat patients, they are not known for having patience. You shout at your patients when the patient wants to convey his distress. You say, okay, next, what is it, etc., etc. The point I'm making is, even if you're not born as a good teacher, if you're interested, you can become better teachers by trying to cultivate lots of things. I think Dr. Naik's presentation was very useful. He made a lot of points which are very interesting. The big problem is, competency-based curriculum and teaching requires more teaching staff. But we don't have more teaching staff. So in the limited time available, how can we improve the quality of our teaching? And that is a skill which we hope by through these kinds of sessions, people will, become aware of and make an effort to do that. I was again personally reminded of one of the points which Dr. Naik mentioned, coordination between disciplines for integration of topics. In fact, today we know that the biggest problem is comorbidity. There is not just a psychiatric illness, there's not just diabetes, it's diabetes and depression. You're hearing diabetes. India is the world capital of diabetes. This morning in another session, I was hearing about how cardiovascular disorders, particularly myocardial blocks, etc., are coming in younger and younger people. And even the cardiologists have started talking about stress and, meditation and various things, which only in the previous 10 years, only psychiatrists talked about. And when psychiatrists talked about that, cardiologists and diabetologists made fun of us. But today they are talking about it. About 30% of people who have. So the point Dr. Naik mentioned is that there has to be a lot of collaborative teaching. For example, back pain is one of the commonest symptoms which a GP sees. They all go to orthopedic surgeons. It's only a few of them will ultimately come to a psychiatrist or, but we know that 90% of the back pain, even the severe back pain, orthopedic surgeon alone or the pain specialist alone is not going to deal with that. The psychiatrist has to be also involved, not to prescribe the antipsychotic medication. So the mind, body medicine, the integrated teaching, etc. I have been teaching at the University of Western Australia. And initially I was very elated. Now I'm not very elated. One of the faculty colleagues in my department, where I used to co-teach, going by what Dr. Naik said, collaborative teaching, is a session on irritable bowel syndrome. It's a primarily gastroenterology. Students are taught this during their gastroenterology posting, but I am called in for the it's not psychiatric posting, it's a regular lecture discussions. And why I have been very elated is the other person who is in that is Dr. Barry Marshall. Barry Marshall is a Nobel laureate. He got the Nobel Prize for discovering, the Helicobacter pylori. When he talked about it, people laughed. Peptic ulcer is caused because of other things and not. And anyway, it took some 30, 25 years for him to get the Nobel Prize. He is a colleague of mine, and I was very much elated when I started. I'm co-teaching psychiatry with a Nobel laureate. Now, of course, that is, so again, that's a very valid point, which means that it is not a gastrologist who will come to psychiatrists and say, let us co-teach. The psychiatrist will have to extend collaboration. And you can collaborate only if you develop that skills. If you think, they are big people, we are psychiatrists, they will make fun of us, it will never happen. Collaborative teaching is very important. That's one way of improving the interest of the undergraduate medication. I've taken much longer than what Ajay would expect, but I justified Sunday morning 60 minutes, since only 10 or 12, 18 or 20 people are there. It doesn't matter a few minutes. So I have enjoyed this. I have learned a lot about the Bilaspur medical setting and teaching of psychiatry as well as Bhubaneswar. Another person whom I know personally is Dr. Sushant. I don't know whether he's still in Bhubaneswar, but he used to be with the All India Institute. So back to you, Ajay. Thank you very much for asking me to say a few words.
Thank you, sir. I'll request Dr. Gopal Das to make some comments in the last. Thank you for the opportunity. Handing over to the Dr. Gopal Das.
Thank you, Dr. Ajay. The program is quite, as usual, it is very resulted in a fruitful learning. And after listening to many of these sessions and interactions, of course, regardless of the borders, regions, as teachers of psychiatry, we have, most of us are facing the same problems across worldwide, I think. So these kind of programs, I would expect this to improve our collaboration and also result in a lot of learning, sharing of experiences, so that in maybe the vision for future, maybe a decade or half a decade later, the scenario hoping that it will change. And always as teachers make us learn, and the younger people, they are no less, we are always surprised by those experiences our younger colleagues and students share to us. These also matter to us, so that we can gear up and meeting their requirements, understanding their needs, which is of course very much the need of our and also many of these sessions will help us in understanding the different perspectives. I would thank all the speakers to have shared their valuable experiences, and Dr. Ajay Kumar to have made the session run smoothly, and of course Dr. Mohan Isaac sir, as always, we always treasure his words, and yet he listens to us patiently all the time. I thank everyone who have attended this session, and we'll looking forward for more such sessions in future. So with that note, I hope we can end this session, and maybe we'll meet in the next one. All of you have a good day. Thank you so much.
Thank you.